Right, so hari ini kita continue with the drugs for respiratory and allergy. Okay. Right. So this is the learning outline. Kita tengok sikit je on the asthma, COPD, allergic rhinitis and cough. So the drugs used for these disorders. Okay. So we want to overview, to refresh that the asthma actually ada dua, which is allergic asthma and non-allergic asthma. So asthma is actually the intermittent obstruction of airflow, okay? Inflammation of the airway system and hyperresponsiveness in bronchi. So the allergic asthma means that the symptoms are associated with an allergic reaction and may trigger by allergens like dust, pet dander, or cockroaches. And non-allergic asthma is characterized as the symptoms are not associated with an allergic reaction. So this may be triggered by exercise, stress, certain medicines, cool or dry air, airway infections, smokes, and other irritants. So they are sharing the symptoms of coughing, shortness of breath or difficulty breathing, wheezing, tightening or pain in the chest. So this is just the overview ataupun refresh what is the asthma. Okay. So some of the medication is given due to the symptoms. Okay. Okay, so this is pathologically, just to remind you all, the comparison of normal bronchiole and asthmatic bronchiole, which is usually dia punya attack, the site of attack is at the bronchioles. Okay, so the bronchial asthma dia nampak hypertrophy, bengkak and hyperplastic. A smooth muscle layer contracts, which is causes the bronchospasm. Okay, with increased mucus secretion, dia ada mucus banyak, resulting in narrowing of the bronchial lumen. Okay, and then that is the condition of asthma. So COPD, okay, is a long-standing allergy reactions. So they consist of the late stage asthma. It is can be chronic irritation due to the smoking, and the condition to always macam recurrence infection that mimics to the inflammation lah. Okay, inflammation. So there are two types of the COPD, bronchitis or emphysema. So dia recurrent. This macam kejap-kejap dia asma, kejap-kejap dia asma. So maksudnya dia ada macam ulang, repeating. Okay, repeating the condition of asthma. So they are, yeah, soalan? Tak ada soalan eh? Okay. So there are two types, which is include chronic bronchitis and emphysema. So chronic bronchitis ni is more to the inflammation and excess mucus, and then the emphysema due to the alveolar membranes breakdown. I mean the structure of the alveoli itself tu ada problem. So both causes shortness of breath ataupun difficulty in breathing. Okay. So kalau bronchitis tu biasanya alveoli okay. Dia punya structure of the alveoli okay, but the structure of the alveoli in the emphysema adalah macam dia punya tu dah ada apa tu rosak lah. Rosak breakdown. Usually the integrity of the membrane cell tu dah apa tu reduce lah. Okay. Okay, so this is the common drugs for the asthma and COPD. Okay. COPD tu apa? It is a congestive pulmonary disease. Okay. Okay, chronic obstruction pulmonary disease. Sorry, chronic obstruction of pulmonary disease. Okay. Kalau tengok the drugs for the asthma and COPD tu lebih kurang sama je. Okay. Kalau tengok asthma ada bronchodilators and anti-inflammatory agents as well as the COPD also ada bronchodilators and the anti-inflammatory agents. So due to the chronic condition of the COPD, okay, they can have combination bronchodilators. Okay. So kalau tengok bronchodilators ni bentuk dia beta 2 agonist, okay, muscarinic antagonist and methylxanthines. So muscarinic antagonist dengan anti-muscarinic or anticholinergic drugs ni sama. Okay, nama dia je. Sebenarnya sama lah. Okay, sama. Anti-muscarinic ni dia lebih kepada macam dia punya effect on the muscarinic receptors. So antagonist lah. Okay. Anti-muscarinic, anti-action of the muscarinic normal punya response. And the anti-inflammatory agents for the asthma include mast cell stabilizers, okay, corticosteroids, anti-leukotrienes, and anti-immunoglobulin E antibody. So additional for that in the COPD, it has also corticosteroids, okay, inhaled corticosteroids, and phosphodiesterase inhibitors, and other they can include antibiotics, mucolytics, and antioxidants because this is chronic, and then recurrent. Okay, dia maksudnya macam dia baik, lepas tu dia ada balik. Okay, repeating lah. Dia baik, lepas tu dia ada balik. Lepas tu benda tu berulang-ulang. Okay, that is the COPD. Okay, right. So the drugs used is the beta 2 agonist ni. Okay, beta 2 agonist means that dia agonist to the beta 2 receptor. Okay, biasanya the ubat tu ialah dalam bentuk inhaler ataupun aerosol lah, ataupun tablet, nebulizer, solution or syrup. Okay, so it include short acting and long acting. Okay, SABA tu maksud dia short acting beta agonist. LABA means that long acting beta agonist. So SABA means that short acting for treatment of acute symptoms of bronchoconstriction. Contoh salbutamol. Okay. So long acting for long term control of bronchoconstriction, LABA. For example, medication is salmeterol and formoterol. Okay. And then the salbutamol for children that is under 5 years, unable to manage lah. So biasanya unable to manage tu tak boleh, susah nak bagi inhaler. Okay. So dia boleh ganti dengan nebulizer, tablet ataupun sirap. Okay. If let's say the children tu, the child tu ada epilepticus, okay, maksudnya dia ada epileptik ataupun sawan tu dia lebih daripada 5 minit. Okay. So susah kita nak manage this patient, so kita akan bagi secara IV. Okay. Okay, diagram ni, okay, the diagram ni tunjukkan dia punya kinetics of the a few types of the beta 2 agonist. Okay, albuterol, formoterol and salmeterol. So albuterol ni hydrophilic, okay. Hydrophilic tu maksudnya dia lebih tend to the attract to water ataupun dia boleh dissolve in water. Okay, and then this albuterol they have short duration. Okay, biasanya not stored in the lipid and rapid onset. So biasanya bagi masa acute lah, acute attack boleh bagi albuterol. And then the formoterol is amphiphilic. So amphiphilic tu maksudnya dia ada both hydrophilic and hydrophobic parts in the drugs. Okay, so this is have long duration. So biasanya retained by lipid and rapid onset. So this one also can be given during the acute attack or the chronic attack. It depends on the condition. And then salmeterol, this is lipophilic. Lipophilic means that this drug is dia attract to lipids and dia boleh dissolve in the lipids ataupun fat. Okay, dia boleh combine. So dia lebih dia boleh retain by lipid, and then dia slow onset. Okay, so because of the slow lipid diffusion lah. Okay, so this is a longer duration, effect dia long duration. Okay, so that is the difference between the albuterol, formoterol, and salmeterol. Okay. Right, this is the mechanism for the beta 2 agonist. Okay, they activate the G protein, adenine cyclase CAMP pathway to cause reduced smooth muscle tone. Okay, causes the muscle relaxation. So beta 2 adrenergic receptors are found throughout the airways. Okay, involved in both smooth muscle relaxation and reducing release of inflammatory cytokines. Okay, bila ada apa tu aktif protein kinase A ni, dia akan causes the influx of the calcium into the cell. So reduced calcium will reduce the binding of the calcium calmodulin at the myosin head. So that's why they can cause the relaxation of the smooth muscle. Okay. So dia sebenarnya okay. This is cholinergic nerve. Okay, they are acetylcholine. Okay, acetylcholine. So this is the binding of the acetylcholine, but actually increase of the agonist of the adrenergic receptors can increase the production of the CAMP. Okay, production of the CAMP, which is can in turn activate the protein kinase A, and the protein kinase A can enhance the influx of the calcium into the cell. So that therefore there is reduced concentration of the calcium extracellular, then reduce the binding of the calcium calmodulin, and then therefore that can causes the relaxation of the smooth muscle. Okay, that is the mechanism, almost the same. Okay. So this is salbutamol description, means that description of the salbutamol. Okay, so it is in the indication of the salbutamol include the treatment or prevention of bronchospasm. So by this time, I hope you understand what is bronchospasm. Okay, bronchospasm is when the muscle that line the bronchi in airway system is tightened. Okay, dia jadi lebih kecil. Okay, in patient with reversible obstructive airway disease. Okay. Okay, dosage for bronchospasm ni okay, ada dua bentuk, aerosol and tablet and syrup. So aerosol ni 2 puffs inhale orally. Okay, biasanya melalui oral, okay, every 4 to 6 hours, but not exceeded 12 inhalations in 24 hours. Okay, for the tablet or syrup ni 2 to 4 milligram orally every 6 to 8 hours, not to exceed it 32 milligram per day in 24 hours lah. Okay, contraindication, they have interaction with the drugs include isocarbocazide, linezolid, phenylzine, sacubitril, and transcranial cypromine. Okay, and then the psychological contraindication include the hypersensitivity. Okay. Side effect of the salbutamol include tremor, nervousness, and insomnia in children. Okay. So the action mechanism of the salbutamol is the agonist to the beta-2 receptor. Is the same lah. Okay, beta-2 receptor agonist with some beta-1 activity. So dia ada sikit to beta-1 activity. So biasanya beta-1 activity ni is actually the receptor lah. Beta-1 receptor tu found in heart. Okay, effects dia relax bronchial smooth muscle with little effects on heart rate. So oral onset biasanya 2 to 3 hours, last for 4 to 6 hours. Okay, half-life 38 hours through the inhalation and 3.7 to 5 hours through the oral administration. It can be metabolized in liver and excreted via the urine. Okay. The effect is the same, which is increase the CAMP and then causes the bronchodilation. Okay, relaxation of the smooth muscle. Okay, muscarinic antagonist or anti-muscarinic ni, okay, dia lebih kurang sama lah. Cuma anti-muscarinic ni dia punya target is the acetylcholine. Okay, tadi tu dia lebih kepada production of CAMP, which is indirectly suppress the muscarinic. Okay, muscarinic. So this one is actually directly muscarinic antagonist. Okay, directly muscarinic antagonist. So they have short-acting muscarinic antagonist, SAMAs. Contohnya ipratropium and oxytropium. Okay, and they also have long-acting muscarinic antagonists, LAMAs, which is, for example, tiotropium, aclidinium, glycopyrronium, bromide, and umiclidinium. Okay, so the main metabolism is the block acetylcholine on M3 muscarinic receptor in airway smooth muscle. So that is the difference lah between the agonist of the beta 2 and then the anti-muscarinic of the in this one muscarinic antagonist. So that is actually the different tadi dia target the production of the CAMP. Okay, so this is beta 2 agonist, and then for the antimuscarinic, they target the M32. So this is the directly target the muscarinic activity tu. So that's why they are named as an antagonist. Okay. So for example here, this is causes the biasanya acetylcholine ni dia causes the constriction. Okay. Acetylcholine response, okay, to the muscarinic receptor ni causes the constriction. By inhibit this response, okay, by these drugs, okay, anti-muscarinic ni inhibit this response, so they inhibit the constriction. Okay, they directly inhibit the constriction. Okay. So, okay, so this description of the drugs include ipratropium, okay, indication for the maintenance treatment of bronchospasm, chronic bronchitis, and emphysema. Okay, dosage dia for the inhaler 2 puffs ataupun about 34 microgram every 6 hour followed with PRN. PRN tu maksudnya prorinata ataupun maksudnya when needed. Bila ada attack ataupun memang ada shortness of breath, tak boleh bernafas, and then boleh bagi this ubat. Okay, but not to exceed it 12 puffs per day. Okay, ataupun 408 microgram per day. For the nebulizer, if let's say the patient use nebulizer, so it could be 2.5 milliliter every 6 to 8 hours. Okay. The peak plasma time is 1 to 3 hours duration. Duration dia 3 to 4 hours. Dia punya lasting dia. Okay. Half life 2 hours. It can be excreted via urine, so definitely it will be metabolized in the liver to process this ipratropium. Okay. Contraindication include hypersensitivity and the administration of the pramlintide. So this drugs is actually the analog to amylin, which is used for the DM treatment injection. Okay. Warning: used for maintenance treatment only because it can cause the life-threatening bronchospasm. Okay. Side effect: fatigue, headache, dizziness, and nervousness. Okay. So there are some metabolites, which is the metabolites is N-isopropyl noropium metobromide. Okay. Phenylacrylic acid and isopropyl nortropine, ester metobromide, and 6 others. So dia punya metabolites ni tak perlu ingat lah. Cuma I just want to share with you. This is the metabolites for the ipratropium. Okay. So nak ingat senang je dia ada ni. Okay. Tropium dia ni. Okay. Tropium dia. Okay. Okay, so the action here, this diagram shows the action of acetylcholine. Okay, acetylcholine ni dia akan ada response to the muscarinic receptor. Okay, muscarinic receptor kat sini. Okay, upon dia punya release of the acetylcholine ni, dia akan causes the efflux ataupun release of the calcium. Okay, release of the calcium can cause the constriction of the cell. Okay, but the ipratropium ni dia akan compete with the acetylcholine. Okay, they compete with the acetylcholine. They bind to the acetylcholine receptor. So they antagonize the acetylcholine by prevent the release of intracellular calcium. So calcium tu tak akan release lah. Calcium tu akan ada dalam sel. Okay. So bila tak ada release of the calcium extracellular, so dia tak boleh ada contraction lah of the smooth muscle. That's why boleh jadi bronchodilators. Okay, so muscle tu relax lah. Okay. Right. So the next ubat is the methylxanthines. Okay. So biasanya for the acute bronchospasm lah. Okay. Bronchospasm. Okay. So bronchospasm tu dah tighten of the after bronchi lah. Okay. The dosage 5 to 7 milligram per kg. It can be given IV intravenous ataupun oral. PO tu oral lah. Okay. Not exceeded 25 milligram per minute for IV. And the contraindication with the some drugs include dipridamole, febuxostate, riociguat. Okay, other condition contraindicated in the hypersensitivity to the drugs, central nervous system disorder, and then seizures disorder and lactating mother. Okay. The peak plasma time for this drug is 1 to 2 hours. And the concentration of the plasma usually can reach to 10 microgram per mil. So it is metabolized in the liver by cytochrome 1A2 and cytochrome 3A4. So this is the most common cytochrome that involved with the metabolism of drugs. Cytochrome 1A2 and cytochrome 3A4. So the metabolites for the methylxanthines include 1,3-dimethyl-uric acid, 1-methyl uric acid and 3-methylxanthine. Okay. The half-life for the methylxanthine in the non-smoker is 8 hours, but the in the smoker is 4 to 5 hours. It's shorter than the non-smokers. So the metabolites can be excreted through the urine, and the clearance is about 1.45 ml per minute per kg. Okay. But some of the drugs is discontinued in certain countries, maybe due to the side effects, but I'm not sure about this. Okay. So the action of the mechanism of action of theophylline, okay, is actually we suppress the response of the airways stimuli. Okay, we suppress the response. Okay, dia ada respon. Okay, agonist ni ialah dia punya stimuli lah. Any stimuli. Okay, any stimuli. So, they actually, the theophylline ni actually inhibit phosphodiesterase. Kenapa? Because phosphodiesterase ni ialah enzim yang convert the CAMP to AMP, 5' AMP. Okay? So bila dia convert, so tak ada lah CAMP. So reduce CAMP causes the constriction ataupun release of the calcium. Okay. So dia nak block the release of the calcium. So that's why dia block the degradation of the CAMP. Okay. By blocking the activity of the phosphodiesterase. Okay. So the side effect of the theophylline, okay, could include nausea, vomiting, abdominal pain, headache, trouble sleeping, diarrhea, irritability, restlessness, nervousness, shaking, and increased urination. Okay. So bila ada increase of the CAMP, they will increase the bronchodilation, muscle relaxation, and indirectly reduce the production of inflammatory cells. Okay. The next medication is the mast cell stabilizer or cromolyn sodium. So this is indicated for the mastocytosis. Okay, mastocytosis. Mastocytosis ni is the excess number of mast cell gathering in the body's tissue. So it is very rare condition. Kalau tengok kat sini is actually, okay, we ada allergen kan. ada allergen, contoh pollen lah. Allergen ni anything that can cause allergic to the and can cause the allergic reaction. Okay. Biasanya dia ada IgE receptor. Okay, dia ada IgE receptor and then increase the binding of the allergen to the mast cell. Mast cell ni beza dengan macrophages ialah mast cell lebih besar daripada macrophages. Okay. So dia binding of the allergen tu can cause hypersecretion, can cause pruritus, sneezing and other migration of inflammatory cell. So they will reduce uh, the response of the ataupun response by the mast cell. Okay. Dosage of this mast cell stabilizer is the 200 milligram orally 4 times per day, 30 minutes prior to meals. Half-life is 80 to 90 minutes, lasts for 6 hours, and then it is contraindicated in the hypersensitivity or severe anaphylactic reaction. Okay, anaphylactic tu means that dia ada reaction lah. Okay, dia ada macam allergic reaction. Okay. So these drugs can be excreted in feces primarily. So mechanism ni is actually inhibits release of histamine, leukotrienes and inhibit degranulation. So they can causes the reduce anaphylaxis, hypersecretion, pruritus, sneezing. Pruritus tu dia rasa macam itchy macam gatal-gatal. Okay, pruritus macam merah-merah hidung. Tak terlalu lama pruritus macam ada melecet lah ataupun macam luka-luka ke. Okay. So this is the mast cell stabilizer. Okay. And then the next drug is the corticosteroid. Okay. So this drug is have a very wide range of inhibitory activities against multiple cell types. So they inhibit activity against multiple cell types. Okay. They inhibit activities against multiple cell types and mediators, okay, which involve in allergic and non-allergic mediated inflammation responses. Okay, involved with the allergy and non-allergic mediated inflammations. Okay, cells and mediators. So the cell include mast cells, eosinophils, neutrophils, macrophages, and lymphocytes. Mediators include histamine, eicosanoids, leukotrienes, and cytokines. Okay. So also activate and increase the expression of anti-inflammatory genes such as MAP and beta-2 receptors. Okay. Contoh corticosteroid is prednisone, buxonide, biclomethasone, and fluticasone. Okay. Okay, the prednisone indicated for the acute asthma, the dosage is 40 to 60 milligram 1 time per day or divided 2 times per day orally every 12 hours. And then this prednisone is contraindicated in untreated serious infection, hypersensitivity, varicella rash, which is commonly treated with the acyclovir, and systemic fungal infection. Okay. So this prednisone has a warning lah. If let's say administer this ubat, so should be monitored closely in Cushing syndrome patient, diabetes mellitus, long-term treatment with osteoporosis, myopathy. Myopathy tu is actually the disease of the skeletal muscle and delayed wound healing. Okay, the side effect may include latent TB. Okay, maksudnya recurrent infection of the TB. Okay, intraocular pressure. Okay, mata, glaucoma, mata, psychiatric disturbances, anaphylaxis, okay, angioedema, bradycardia, cardiac arrest, acne, dermatitis, weight gain, and etc. Angioedema tu, if I'm not mistaken, is the edema underneath the skin. Okay. Okay, the action mechanism of prednisone, it is a corticosteroid. Okay. It is a corticosteroid. So it is a little bit different lah daripada tadi. Tadi tu lebih pada muscarinic response. Okay. Muscarinic response. This one is the action of prednisone, which is the corticosteroid. Okay. So they directly suppressing migration of polymorphonuclear leukocytes. Okay. Stabilizing lysosome. Okay. Lower dose replace deficient endogenous corticosteroid, and higher dose decrease inflammation. So that is the target, because inflammation is one of the symptoms in the allergy ataupun respiratory disorder conditions. Okay. So the bioavailability is 90%, 90%. Half-life is 2.6 to 3 hours, lasts for 60 minutes. Okay. Extensively metabolized in the liver, hydroxylated to active metabolite. So what is the mechanism of the prednisone? It is actually the corticosteroid ni, okay, prednisone ni can enter the cells. It enter the cells and bind to the glucocorticoid receptor. So glucocorticoid receptor ni can react with the glucocorticoid response element. The response element here, which is directly or indirectly bind to the CBP, PCAF, and CRC1, SRC1. Sorry, and then they have had, okay, they have had activity, okay, which is this binding causes the acetylation of lysine on histone 4, okay, which leads to the activation of genes encoding anti-inflammatory protein, for example, SLP1. Okay, so they encode the proteins, which is the proteins for the anti-inflammatory response. So they will release the anti-inflammatory proteins. So that is the mechanism of prednisone. Macam mana dia nak block atau macam mana dia nak reduce inflammation. Okay. Okay. Pycnite, okay, this is a synthetic corticosteroid. The indication for the pycnite is intranasal spray for nasal symptoms of seasonal or perennial allergic rhinitis. Okay, seasonal tu dia ikut musim lah. Okay, perennial ni means that dia tak kira lah apa musim pun dia mesti ada rhinitis tu. Okay, rhinitis. Okay, the dosage is 32 milligram ataupun puff. Okay, so for example, rhinocort allergy ni, nama ubat ni OTC, over the counter, boleh beli je kat counter. Okay, for the allergic rhinitis ni biasanya dia punya dose 64 microgram per day, okay, ataupun one spray, not exceeded 4 sprays per day. Okay, bioavailability for the pycnite is 34% nasal mucosal absorption. Half-life is 2 to 3 hours. It is metabolized by the cytochrome 3A4 to 16 alpha hydroxyl prednisolone and 6 beta hydroxyl pycnite. Okay, so it is excreted primarily in the urine, 66%, and feces the balance lah, the rest. Okay, the side effect include immune disorders, increased intraocular pressure, cataracts, glaucoma, nasal septum perforation, throat irritation, burning throat, wheezing, and growth suppression. Okay, this is the action of pycnite. Okay, so they inhibit cells and mediators respond to antigen or allergy, activate and increase expression of anti-inflammatory genes such as MAP and beta-2 receptors, so reduce exacerbation of inflammation due to allergens antigen. So pycnite ni lebih kepada reduce inflammation. So this is got nothing to do with the bronchodilation ataupun bronchoconstriction. Okay, macam mana the action, the mechanism of action of pycnite is actually, okay, this is the inflammatory stimuli. Anything lah, okay, allergens ke ataupun any condition that can cause the vasoconstriction through the, anything that can cause the inflammatory reaction. The inflammatory reaction through the activation of the nuclear factor kappa B. Okay, nuclear factor kappa B means that inflammatory stimuli ni dia akan activate the nuclear factor kappa B ni through the detachment of the inhibitory alpha protein. So this is inhibitory alpha protein. So phosphorylation of the inhibitory alpha protein will detach it from the nuclear factor kappa B. So nuclear factor kappa B ni can causes the production of the inflammatory genes which is can increase which is can produce the inflammatory proteins include cytokines, chemokines, adhesion molecules and inflammatory enzymes. So if let's say there is administration of bisonide, okay, bisonide. So bisonide actually is a glucocorticoid. So samalah dia akan enter the cell and then bind to the glucocorticoid receptor. So they will directly causes the production, okay, through the binding to the CREB, okay, CREB directly or indirectly, and then causes the production of the anti-inflammatory genes, and the binding of the bisonides to the receptor can cause the inhibition of the nuclear factor kappa B activity. So this reduce the production of these genes, production of the chemokines and cytokines, and then increase the anti-inflammatory proteins production. So this is how the bisonide can reduce the inflammation. Okay. Okay. So ini contoh proteins yang anti-inflammatory protein lah. So dia directly bagi apa tu signals ataupun instruction to the gene. Okay. Instruction to the gene untuk stop the production of this inflammatory proteins and then increase the anti-inflammatory protein productions. Okay. So another drugs is the phosphodiesterase inhibitor. Okay, contohnya. So sebenarnya tak payahlah ni kan sebab PDE ni memang dah phosphodiesterase 4. Okay, phosphodiesterase 4 inhibitors. Okay. So saya ni silap ni. Okay. So this is indicated, okay, reduce risk of COPD, chronic obstructive pulmonary disease, exacerbation. Maksudnya makin teruk kan. Dia nak reduce risk tu. Supaya tak makin teruk lah in history of exacerbation and associated with chronic bronchitis. So pada patient yang memang pernah ada attack yang teruk, okay, yang teruk dan juga ada chronic bronchitis, boleh bagi phosphodiesterase ni, okay. So the dosage to 500 microgram per day oral to adjust dose in starting treatment and renal impairment. Okay, because this dose ni kena adjust lah kalau orang tu mula-mula start treatment, okay, ataupun ada renal impairment, okay. And 80% of these drugs is absorbed, protein bound, okay, they bind to the protein, and peak plasma time is 1 hour, active metabolite is in 8 hours, okay. Extensively metabolized in liver via cytochrome P450 and conjugation reaction, okay. Half-life dia about 17 hours, and oxide ni dia punya metabolites lah about 30 hours, okay. And then it can be primarily excreted to the urine, okay. Phosphodiesterase inhibitors ni contraindicated in the acute bronchospasm, hypersensitivity, liver impairment, psychiatric disorders, okay, ataupun ada administration of the cytochrome 3A4 inhibitors or weight loss. Okay. The side effects include nausea, reduced appetite, abdominal pain, diarrhea, and insomnia. Okay. So the action mechanism of roflumilast ni yang tadi lah, maksudnya the PDE inhibitors tu, dia akan inhibit the PDE. So sebab PDE ni dia punya function, dia akan tukar CAMP to AMP. So by inhibits this enzyme activities, so they will increase the CAMP. So increase of the CAMP will increase the PKA, which is inhibit the activity of the nuclear factor kappa B, and then reduce the cytokines or any chemical that causes the inflammation, and directly causes the activation of the CREB, okay, which is increase the cytokines working against inflammation. Means that CREB ni increase the production of the anti-inflammatory proteins. Okay, anti-inflammatory proteins will reduce the inflammations. Okay. Okay, leukotrienes inhibitors, all the cysteine leukotrienes are potent constrictor of bronchial smooth muscle, causing microvascular leakage, okay, eosinophilic and mast cell-mediated inflammation. Okay. So, leukotrienes punya respon tu boleh menyebabkan berlaku constriction of the bronchi, okay, bronchi smooth muscle, and then cause the inflammation. Okay. So it include C4, okay, D4 and E4. Okay. Leukotriene inhibitors tu dia nak inhibit the leukotriene. Okay. It is the receptor antagonist, which is montelukast, zafilokast, and tranlokast. For the this one is the 5 lipoxygenase inhibitors. For example, Xylitol. This is not as effective as steroids, less effects on airways inflammation, but maybe useful as add-on therapy. So this one can maybe, if let's say the patient is not responded to the first line drugs, boleh bagi, okay, boleh bagi leukotriene inhibitors to see whether that is because of the leukotriene activity or because of the other condition, okay. Okay, so montelukast ni high affinity competitively antagonist to leukotriene D4 and leukotriene E4 indicated for the prophylaxis. Prophylaxis tu is the treatment, prevention treatment for the attack. Okay, and chronic treatment of asthma, prevention for exercise-induced bronchospasm, and perennial allergic rhinitis. Okay. Dosage asthma is 10 mg single tablet orally every afternoon or evening. Okay, and yang penting PM. Okay. Exercise 2 hours before exercise, not exceed 2 doses per day. Perennial allergic rhinitis ni maksudnya orang yang ada allergic tu dalam tempoh yang panjang. Okay, tak baik-baik. Ni tak baik-baik. And then can be given lah, boleh bagi ubat ni 10 mg single tablet orally 1 times per day. Okay, so the half-life is 2.7 to 5.5 hours. Availability is 64% and executed in the feces primarily. Okay, so this is the action. Okay, they inhibit the leukotrienes receptors so that they will inhibit the all the effects of the leukotrienes. Okay, mucus secretion, bronchoconstriction, eosinophil recruitment, and plasma exudation. So bila plasma exudation ni macam increase the activity of the leukotriene, which is can increase the bronchoconstriction and then the inflammation. Okay, so they inhibit the receptors. Okay. Antibiotics and mucolytic. Okay, this one regular use of macrolide antibiotics to reduce exacerbation rate. So means that kalau contohkan tadi that is the condition of the chronic bronchitis. Chronic bronchitis dia ada banyak mucus. So boleh bagi mucolytic. Mucolytic tu maksudnya something yang boleh pecahkan mucus tu dan increase the ciliary excretion. Okay, so example is ubat tu ialah carbocysteine and acetylcysteine. Okay, anti-Allergy antibody, or it is a recombinant humanized monoclonal antibody bind to the IgE. Okay, IgE, if you still can remember, ada pada mast cell. Biasanya ada pada mast cell, ada dia punya receptor tu, and inhibits binding to IgE receptor on mast cell and basophils. So prevent allergy reaction at early stage of reaction process. So other this thing you can baca later. Okay, so this is a summary of the an effect of the omalizumab. Okay, so this is one of the medication used for the to reduce the inflammation. Okay, allergic inflammation. Okay, this one boleh baca je ni. Okay. Antihistamine, okay, Allegra, okay, indicated for the seasonal allergic rhinitis biasanya ataupun chronic idiopathic urticaria hives. So maksudnya biasanya hives ni allergic reaction lah. Okay. Idiopathic tu maksudnya tak tahu apa sebab dia. Okay, tak tahu. Okay. Dosage dia 150 mg oral, contraindicated with the grapefruit. Kenapa? Tak boleh makan anggur pula kalau makan antihistamine ni sebab dia involved with the dia involved with the protein, okay, protein transporter of the antihistamine in the cells. So that's why dia tak boleh makan anggur kalau ambil antihistamine ni, okay. So kalau that patient ada hypersensitivity ataupun severe renal impairment because this antihistamine ataupun Allegra ni contain phenylalanine, okay. This is the action. They block. This is the H1 ni. Sorry, the Ilagra tu is actually H1 histamine receptor antagonist. So they compete with the stimuli and then block the action of the H1 receptor. Okay, therefore can cause the vasoconstriction and bronchodilation. Okay, also reduce the inflammation by inhibit cytokine and release. Okay, cytokine production and release. Okay, cough. Okay, cough another. This is a reflex. Okay, reflex reaction. Okay, biasanya due to the bronchopulmonary infection. Okay, atau contoh bronchitis or pneumonia and environmental causes. Contoh cigarette smoke or other air pollutants. Okay, biasanya chronic cough ni they last more than 2 months, okay, because of the airway hyperactivity, post-nasal drain, okay, gastroesophageal reflux, atau GRED, okay, GRED, lung cancer and ACE inhibitors, okay. There are two types of the cough, productive cough and non-productive. Okay, cough, productive cough ni biasanya ada secretion, okay. Non-productive ni dia tak ada secretion tapi dia biasanya ada due to the chemical thermal or inflammatory inflammatory punya response. Okay. So because cough ni dia due to the reflex, okay, the reflex and then it is ada related with the brain, okay, with the brain. So kita boleh bagi cough suppressant, okay. It is an antitussive, okay, which is control, inhibit and eliminates cough, okay. Suppress intensity, frequency and distressing cough, okay. Act on cough center in the brain medulla to decrease cough reflex, okay. Ada peripheral, central and peripheral and central as well, okay. So a common cough suppressant ni ada dextromethorphan, the isomer of codeine analog, codeine which opion for codeine, and then diphenhydramine, okay, antihistamine, which is target on the CNS and especially reflex depressant, okay. So this is the dosage of the dextromethorphan, okay, liquid syrup 10 to 20 mg oral every 4 hours to 30 mg every 68 hours. Lozenges, okay, 5 to 15 mg oral every 1 to 4 hours, not to exceed 100 mg in 24 hours, okay. So yang lain tu boleh baca. Okay, the action mechanism dia, there are two ways. The first one is actually they inhibit the action of the serotonin transporter and noradrenaline transporter. Okay, and then the B as a channel blockers. And then this channel blockers NMDA and methyldiaspartate glutamate receptors ni is actually in the brain. So this is actually the involved with the mechanism of cough reflex reaction. Okay, reflex reaction. So the dextromethorphan ni dia block the proteins, okay, at the serotonin and noradrenaline, and also as a channel blockers. So they block the cough reflex. Okay, they block the cough reflex. Okay, this is the metabolism of the dextromethorphan in the liver, which is the dextromethorphan can be converted to the dextrophon by the cytochrome 2d6, and then this is blocked by the quinone and increasing by the uh, bioavailability of the dextromethorphan. And then also the dextromethorphan, if let's say it is reacted with the cytochrome 3A4, it can produce the 3-methoxymorphinin, and then blocked by the quinone. Okay, so this is the metabolism. So UGT means that UDP glucuronidase transferase. Okay, this is one of the enzyme in the liver. So this is the metabolites, and also they can produce the conjugates of the dextromethorphan. So biasanya conjugates ni akan lebih ataupun this one also glucuronide is lebih dissolved in water. Okay, co-expectorant. Okay, expectorant tu maksudnya medicine for cough that help releasing the clearing the phlegm. Okay, phlegm maksudnya mucus. Okay, dia expectorant. Expectorant tu maksudnya dia untuk clear mucus. Okay, dengan cara reduce viscosity of mucus secretion and increase amount of secretion fluid and expulsion facilitated by ciliary action. And the drugs usually contohnya guaifenesin. Okay, so they increase the ciliary action. So they want to clear the mucus. So this is called expectorant. Okay, so this is the description of the guaifenesin. You can read. Okay, so this is mucociliary agent. Also sama. Okay. Okay, this is beta adrenergic receptor distribution. Okay, this is some of the just recap from the physiology. Okay, as you can see here, production of the PKA increase the influx of the calcium into the cell, which is if let's say there are release of the calcium can cause constriction. But bila ada influx, dia akan store. Dia akan simpan kalsium dalam sel. So tak ada reduce calcium concentration kat luar. So dia tak akan ada calcium calmodulin binding which is can increase the which is can cause the constriction of the muscle. So bila ada influx, so dia boleh menyebabkan berlakunya relaxation of the muscle. Okay. So this is another drugs, also the same mechanism is the activation of the PKA ataupun kinase A, sama. Okay, and then the congestant agents also is actually the, for example, phenylpyrin, okay, pseudoephedrine and oxymetazoline. Okay, this is the adrenergic receptor agonist. Okay, act on alpha receptor and beta receptor. So alpha receptor ni lebih kepada vasoconstriction, okay, can reduce swelling or shrinkage of the inflamed tissue, and then beta receptor in myocardium. So myocardium tu biasanya B1 lah kan, okay, increase heart rate and force contraction. Okay, so they will increase the this is the congestant agent. Okay, that's all. Ada soalan?